All right, I think I have 12:02. We have quite a few people joining and already on the line. If you can just let us know in the chat who you are and what facility you're representing, that would be really helpful. I'm going to go ahead and share my screen. All right, can you all see Kelly? Can you see this? Okay.
I can.
Okay, great. All right. Well, welcome to our Zoom meeting for the Readiness Cost Survey for Level 3 and Level 4 trauma centers. I'm just going to give you a brief background because we've got a lot of content to cover. We want to make sure that we get to your questions. You've received a lot of emails from me, so if you've not met me before, I'm Liz Atkins. I serve as the Executive Director for the Georgia Trauma Commission, and many of you receive funding from us. And I'm joined today by Dr. Regina Medeiros, who is one of our Trauma Commission members. Regina actually serves as the Secretary Treasurer for the Georgia Trauma Commission and overseeing the flow of funds, and very interested in moving this project forward. Also have Kelly Vaughn, who is a very active member of our rural level 3, level 4 subcommittee, keeps our chairman, Dr. Patterson, in line. I think, Kelly, that's your primary goal there. And then also Jessica Story, who is from Warren Averett, who does the audit on this project, has helped historically. You're going to get a little bit of a historic background on this, just to kind of give you some background on what we're trying to achieve with this. So with that, I think I will turn it over to Dr. Medeiros, and she can kind of give you a little bit more insight on the background. Dr. Medeiros?
Thank you, Liz. I appreciate that welcome. And I'd like to extend a welcome to all of you and a thanks to you on behalf of the Georgia Trauma Commission. As Liz mentioned to you, my name is Regina Medeiros, and I'm the Secretary Treasurer for the Commission and the Budget Subcommittee Chair who allocates the funding for the trauma centers. And I want to thank you all for your work on this important project. We're hoping that this work will help us to better understand what the financial landscape looks like in relationship to readiness costs associated with care provided in level 3 and 4 trauma centers. We don't really have a good understanding of that. We anecdotally have some ideas, but this is really a good step in trying to identify those costs. And we are very aware that this is no simple task. This is a big undertaking. This is a large survey. I'm sure you guys have a million questions already circling in your mind, so I won't take up too much more of your time. But I do want to let you know that we've done this before. We've done 2 readiness cost surveys already with the level 1 and level 2 trauma centers. And we were able to fine tune the process since we've done it a couple of times, and identifying that really we are providing only about 10 cents on the dollar to trauma centers for the delivery of care for readiness costs associated with that. So, it'll be good to see how does that relate to the level 3 and 4 trauma centers and so forth. We need you to know that the current administration legislatively is very focused on healthcare disparities and access across rural areas. So the timing of this is key. And we'll be working to share the information that we obtain from this readiness cost survey with them to let them know sort of what your needs are. As many of you have been involved in the system for quite some time, the 3 and 4 trauma centers have received a flat rate stipend, so to speak, of funding. And we really don't know, is that the right way to do it? Is there a better way to do it? So we'll be taking the information from what you gather from this readiness cost survey and putting it with other information and sharing it with the administrator group to look at how the funds are allocated and distributed. So know that the work that you're doing today, and when you start pulling your hair out in the next few weeks to start filling out this survey, it's really important. Stick with it, ask questions. We're all here to help and support you with it. And we will all be successful and better for it. So with that, you didn't come to hear me talk, but I did want to give you a little bit of background. You did come to hear the rest of the team share with you what the survey is all about and how you need to go about filling it out. So I will turn it back over to Kelly and Liz and Jessica, and they'll get to the meat of what you're here for. But thanks again.
Great, thank you. And yes, we did share with you, I shared with you all the two manuscripts that were actually published on the prior level 1 and level 2 readiness cost surveys. So that data created a powerful story with the legislators. And I think, again, given, as Dr. Medeiros mentioned, the intense focus around rural healthcare disparities in this current administration, I think the information, the timing is great around this because we hope to have this ready for you to look at prior to the legislative session. So that should be great. So next, you can see the main part of this is going to be focused on the tool, but we just want to go over really quick. Jessica and I will review the project timeline. And I have this up. You received this document in your email as well. These are just some key dates. And you see the first, it starts off with our meeting that we're having today. We want to schedule. I didn't want to send this out, an invite out for fear that you might think we were rescheduling this, this webinar. So we will have a follow-up meeting in the same fashion, just to go over your questions and answers, because as we have experienced or have experience with this before, we know that questions will come up, and we want to way, instead of going back and forth in email and phone calls and things, just for you to be able to jump on a call and do that. In order to be successful with that, we'd like you to try to look at this tool after you get this information today and have those questions into us by the 15th, so that we can have time to research if it's something a little bit more complex, and maybe we have to go back and look at the prior surveys to find out how we dealt with that. New questions always come up, so we may have to create a new rule that that folks follow. So that questions we'd like by the 15th of October, and then I will send you a Zoom link for another virtual session on the 21st. We'll do the same time, like around noon. It seems to work well for lunch. I know you don't want to spend your lunch with us, but it's just the easiest way to schedule. And then we'd like this completed survey tool by the 29th of October. And then Jessica, if you can just share what you do once you receive the information from the centers.
Right. Okay. Thank you, Liz. Yes. So October 29th will be the due date for the actual survey. And what I'll do on my end is set up a secure file sharing site. It's a proprietary share file system that we have at Warren Averett. It's actually called Warren Averett Connect. And so after this meeting, if you can please email me, my email is actually included in the survey. Email me the contact person at your center that you would like to have access to this file sharing site. I'll need their name, their title, and their email address. And so I'll send those out. You will submit your survey to me through that secure site. Once I receive those back, we will compile the information, analyze the information included in the survey, and then we'll use sampling techniques to actually select some costs to validate. So, I guess the next date, November the 12th, is the whenever we will have our information selected and sent back to you. So if we have questions that we maybe need more information about that you've included in your survey, and then also the support will be due back by November the 12th. And that we can talk about that support when we get into the survey a little bit later on, but we will be actually testing the costs that you've included in the survey. And so that's due back November the 19th. During the time between November 19th and December 17th, we'll actually be going in and validating your support to the information that you included in the survey. There may be some phone calls or Zoom calls requested during that time, just so that we can make sure that we're understanding the information that was submitted in the survey. And then by December 17th, we should be completed with that testing round. And then by January 21st, Lauren Averett will have our report ready to submit back to the Trauma Commission.
Thanks, Jessica. And then we would like to share that report with you all so that everybody can sort of see what we're looking at, what results we got, and what it looks like, because certainly we want you all to be part of it before we take this to the legislators and kind of make this our burning platform, so to speak, for why we need to continue with our current support as well as get additional support. So that is the project timeline, sort of in a nutshell. I'll stop sharing this for a moment, and then I will bring up the tool. And Kelly, who has spent a lot of time on this tool for you all to make sure that we get this right. I will turn it over to her. And here you go, Kelly. You should be able to see
Got it.
the tool now. And is it big enough for you?
It is.
Okay.
It is. But I need you to go up to like row 1, if
There
you
you
don't
go.
mind. Okay,
Mhm.
perfect. All right. So welcome, everyone. My name is Kelly Vaughn. I am the Trauma Program Manager here at Archibald in Thomasville, Georgia, and I'm going to go over the tool with you. So just an overview of the tool, a couple of things I want to mention. First of all, this is basically the same tool that was used by the 1 and 2 centers. We did do a few modifications, but overall the core of it remains the same. We really wanted to keep that moving forward as we present this to the commission, making sure that we're still reporting apples and apples, just like we did for the 1s and 2s. Also, as I explain the tool, you're going to see resources required by level. And I just wanted to add here that if the resource is not required for your level, but you do have it, we want you to report those costs. So just know that moving forward, I'll hit that as we go, but it's just an overview point that I wanted to make. You'll see this tool is divided out. Overall formatted on the left-hand side, column A, you've got rows. I'm going to refer to those rows, whether you have this online or you've got it printed. As we move through this, I'll refer to row 10, row 17, you'll know what I'm talking about. And then there are areas that are grayed out. Grayed out areas are for most likely applied to levels 1 and 2. And we did try to remove those that we knew or we assumed most likely level 3s and 4s would not have. So here we go. Rows 1 through 7, that's going to be your demographic information. Again, trauma center name, survey completed by, all just regular demographic info. The other thing you'll see that was changed as of this week is that we're doing calendar year 2019. After reviewing this survey many times and thinking through costs for trauma centers, we recognized as we're asking for different costs that 2020 may have impacted, COVID may have impacted a lot of these costs, whether it be education outreach, travel. And so we are asking centers now to look at calendar year 2019 and not 2020. Liz, before I go any further, do you want to say anything about that?
Yeah, just that, I mean, really just underscoring what you said, Kelly. 2020 was really an aberrancy. I would highly doubt you had anybody traveling that year to do anything. So I think we just assumed that 2019 would be the best representative year of what would your typical costs would be.
All right. And then on the right-hand side, rows J, K, and L for, not row, columns J, K, and L, you can see your CFO name and CFO signature. So that is when you finally have the tool ready and are ready to submit, your CFO is going to sign, just validating that the information that is being submitted is the most accurate it can be. Under that, for your trauma program managers, are some green and blue columns, and that is your registry information. So for 3s and 4s, what we want are the total number of records that met your criteria for calendar year 2019 in green, And then for the blue, the total number of records of admitted patients. Now, as you see moving forward, there are going to be rows that are going to correspond to these color codes. The reason is because as we go through these resources, some of these resources apply to inpatients only. So your formula will be number of records of patients that were admitted. That's when we're asking for records for inpatient resources, we only want to know your admitted patients. And then there are some resources that are for all patients. And when that's the case, you'll apply your number of records for the calendar year. Row 8 discusses the confidentiality of the hospital data. And Jessica, you may want to talk a little bit about that and what we're going to do with the data. It
Yes.
won't be individual hospitals. So go ahead.
That's right. Yes, the information, when we report this out, it will all be on a consolidated basis by level. So there will not be any information shared by particular trauma center. So, that's just important to note. I think you can look in the report that Liz sent out, and you can see how that information is consolidated by level. So it will not be shared on a per trauma center basis. And also it will be kept confidential, as I was mentioning before, using that secured file sharing site. Your information will be kept secure and confidential.
All right. Thank you, Jessica. So row 10 and 11 are line items. You'll see with your line item in parentheses, it says with ACS criteria. Liz earlier this week sent you a web link to the American College of Surgeons Resources for Optimal Care of the Injured Patient. That is what, from a trauma program manager perspective, we consider our Bible. That's what tells us what we have to do to maintain designation. So when you look in that book, there's a chapter 23 is kind of the quick reference guide of all the criteria. And in parentheses, by the criteria, you'll see numbers. So moving forward in this document, once you see the row and you see the actual line item, you're going to see numbers in parentheses. Those numbers reference this quick reference guide and also the chapters in the book. So if, for instance, if you look at line 16, you see 2-3, that's chapter 2 of the book. You can look in the quick reference guide and find 2-3 and see what it says, or you can read in the book, refer to chapter 2, find the paragraph that even says in parentheses 2-3, and you can read more information related to that standard. So we're trying to put that there. So when you're trying to go through this tool and you're thinking, why in the world are they asking me this question? You have the criteria of why ACS says it's important. So you can go back and get the validation behind the reason we're asking. The next column is the level. So how it applies if you're a 1, 2, 3, or 4. Again, this is the tool we used for 1s and 2s. So we have just kept it just like it is. And you can see what criteria is required for each level. The next column is your actual survey instructions, which tells you how you're going to calculate these things. And then J, K, and L get down to the financial pieces of that. Sometimes it's asking for % of time. Sometimes it may ask you for a number of FTEs. And then you'll have salary, benefits. And then column L is going to be your total. There are some of these criteria that we ask for. We're just going to ask for total cost. We're not going to ask you how you figured this out. But there are some where you can put in percentage or salary or FTE to help you calculate. Now, Jessica, do you want to talk through supporting documentation really quick before we move forward?
Yes. So what I would suggest is when you're going through and completing the survey, that you are saving the information that you're using to come up with these totals. For instance, if you're having a salary in row 14, we're going to be more than likely selecting that as a to test. So if you can save the contract or the payroll report or whatever it is that you're using to compile that data, I think it'll make it a lot easier in the testing phase that you'll already have that compiled. Also, if your total expenses is made up of a list of expenses, it is also helpful to include an additional tab within the workbook that includes that list. If you're pulling a list from a general ledger detail, for instance, of total cost, that will help when we're making our sample selections to narrow it down to not just a total, but we have a detail that we can select that from. So those are just some suggestions as you're completing the survey to make the testing round a little bit easier.
All right. So with that being said, let's move on into the tool. So row 14 is your senior administrator support. So this is defined as your highest level senior executive that has oversight and accountability for trauma. So whoever that one person is that your trauma program manager, trauma coordinator, whatever you call them, whoever they report to on a senior executive perspective, what their percentage of time is spent on trauma. So you will allocate that out and report that in your actual costs. Row 16 is your trauma program manager or whoever assumes the role for trauma in your center. Their salary, their time, percent of time spent on trauma. Row 18 is we've grayed out 15 and 17 because typically you've got either the program manager or a coordinator. And then in the 1 and 2 centers, a lot of times they may have a director, but not typically in 3s and 4s. That's not your medical director, by the way. That's a true trauma director. Row 18 is participation for costs for state, regional, and national activities. So this is any travel that may have occurred from the administrator's perspective. So your coordinator that may have gone somewhere, your senior executive that may have participated in something, your registrar, any kind of, if you have a PI nurse, where they went, this is where those travel costs are reported. Row 20 through 23 are your other, there are other positions in your organization. So being a 3 or a 4, you may actually, this applies to level 3s only. You may not have someone that is a trauma education or trauma outreach coordinator or trauma injury prevention person. In that situation, let's say marketing helps you a lot with some of your outreach or your injury prevention. If you have people in your facility that help you promote injury prevention and your trauma person works with them on a regular basis, you can report that time here. Some level 3s have a true trauma PI coordinator, and if you do, you report that. If you have someone in quality that helps you, you can report that here. That's your 20 through 23. Rows 24 and 25 are related to the registrars. So if you have an employed registrar, of course, you can just report their salary information. If they are contracted, depending on how they're contracted, some are contracted by record, some are contracted by the hour. And of course, if they're paid by record, again, you're just going to amount of money per record times the number of records and report that out for 2019. If it's an hourly rate, you can report that. 26 is your trauma program secretary. And if you have someone dedicated to trauma or someone who is in another position but allocates some of their time on trauma, you would report that information. Jessica, do you have anything to add on that?
I don't think so, Kelly. That's good.
All right. So let's move on down to rows 27. Now we're kind of getting into the clinical side of things. So years ago, when we developed this tool, we came up with a uniform standards multiplier was developed to help determine number of FTEs that it takes to work with trauma patients. So here is where we see the green and blue colors again. So row 31 is your all patients, and row 32 are just your inpatients. So with that being said, you'll input the number of registry records into column J for all patients on row 31, and then inpatients column J, row 32. And that there's a formula built into L so that if you put a number in, it's going to automatically calculate your FTEs. Once it does that, it will also take the number from L31 and L32 and input it down into J34 through 38. You're going to see that auto-populate. So what it's doing is taking, for instance, let's look at row 34, it's respiratory therapy. Respiratory therapy touches patients, whether they're in the emergency department, inpatient, wherever they're located. So it's going to pull the FTE from 31L and then apply it. Once you do your average salary benefits for respiratory therapist, it's going to calculate all of that out into your actual cost for 34L, if that makes sense. The same thing goes for 35 through 38. You're going to take your average salary for those positions. It's going to apply it to the FTEs for the inpatients, and you'll get your actual cost. So that section is clinical, and it's fairly simple, I think, if you can get your average salary and benefits to determine. All right, Liz, let's scroll on down to, all right, so now we're in the trauma medical director role. Now here is where your physician that has been allocated to, with their specialty interest in trauma care, for level 3s, it's a surgeon. For level 4s, I think they can have a different provider. It may be an ED physician that is defined as the trauma medical director for your center. A lot of facilities pay these physicians to assume that role. And when you do that, whether it's part of their FTE carve out or it's a stipend, that money needs to be reported here. Also, as part of that role, these docs are asked to participate in national, state, and regional activities. And when they do that, again, that's a cost to the organization for them to travel. So we are asking that you report out any costs that you have paid to these physicians to travel to whatever meetings that they needed to go to. Also required for level 3s are ED liaisons, ICU surgical liaisons, ortho, and neurosurgery if you have neurosurgeons. Some facilities do have to pay an administrative stipend to these people. A lot of times from a trauma program manager perspective, these are your physicians that sit on your trauma committee. So not only are they're sitting on your committee, but they're your go-to when you have a quality issue to take back to their group to try and improve care. So if as a facility you have to pay these people, whether again it's through their FTE carve out or a stipend, this money gets allocated there. Row 46 is your trauma registry. So again, a lot of facilities are through our state contracts. We do have money that is allocated for our software, our maintenance. That does not matter here. We want you to report full cost. There's no, do not assume that money, that you're not going to count that cost, because we need to know overall cost for the organization. We know, Liz reported earlier, we know how much facilities are getting through the commission for their designation. What we need to know is overall cost. So please don't reduce it by the state grant amount. Report full cost here in your registry hardware and software. 47 and 48. So years ago when this tool was created, SBIRT, which is what it was called, and TEG were new initiatives that were being heavily pushed by the American College of Surgeons. So we kept those two clinical interventions on this tool. If as a level 3 or 4, as a 3, we are required to do screening, the screening part of the SBIRT. As as far as TEG goes, some facilities have it, some don't. If you do have that in your facility, and you can report those costs here. If you have questions about how to report those costs, Liz, I think you were the one that suggested they could reach out to the commission to help determine costs on that, right? For TEG.
Absolutely. Yes, absolutely. We will make sure if there's any question about it, if your facility has it, there might be a few level 3s that have it. I would highly doubt there's any level 4s that have it, but if you do have it, I'm happy to help.
All right, so we move on down to our clinical medical staff. So here is where we talk about how our physicians are compensated for providing care in our trauma centers. Now you can see we grade out lines 53 through 55. Those were descriptions related mainly to residents and faculty. So we're going to look more at 50 through 52. So this is if you are paying a specialty a stipend for providing ED call for trauma patients, then you report that in this area. If you employ your physicians and they are, because you're a trauma center, that rate is higher, then this is where you try to determine that cost. And you can see in parentheses, we've written salary plus benefits minus pro fee reimbursement. And then you have to estimate that portion attributable to trauma. I will tell you too, like Jessica said earlier, all of this information is reported out only in an aggregate form. So no facilities will know what other facilities are doing. Is that correct, Jessica?
Correct, exactly, Kelly, yes.
So it will be reported out as a level, like trauma center levels, but not with specific facilities. And if you look back at the articles that Liz submitted earlier in the week, you'll see this same information for level 1s and 2s was reported out in those articles back in 2016 and 17. So when you go down, you can see that we list subspecialists first, the surgical and trauma subspecialists first. Now you have trauma surgery, ortho, anesthesia are all listed for 1s, 2s, and 3s. Now, neurosurgery is desired, but it's not required. However, if you're a 3 and you have neurosurgery, that needs to be reported out here. The rest of these, hand, microvascular, cardiothoracic, OBGYN, ophthalmology, oral, maxillofacial, ENT, and plastics, and even critical care medicine are not required. However, we know that a lot of our level 3 centers do have these resources, and maybe some 4s do, I'm not sure. If you do, and if your organization pays these services or these specialists for trauma, what they provide for trauma patients, then that needs to be reported out here. As we go down further, you'll see row 70 talks about critical care. It defines critical care intensivist. And further down, we talk about pulmonologists. Depending on what you have in your center, most likely you will report out either row 70 or I think it's row 82. So depending on what you have in your center, you'll report out your critical care intensivist and the care they provide in the ICU, or your pulmonologist and what you pay them to help you with your ICU trauma patients. Now, that being said, if you do not admit trauma patients into the ICU, into your ICU, then there's no need for you would put 0 here because there's no care provided to those patients in your unit. All right, rows 72 through 74 are more of your surgical subspecialists. You have radiology, urology, and vascular. Again, there's descriptions there, a portion of hospital net cost. And then row 75 talks through the medical specialists. So we have emergency medicine physician coverage. The 4s do discuss either emergency medicine physician or advanced practitioner. So if you have depending on what you have in your center, you will report out your costs from an emergency medicine perspective here. ACS for 3 does require board certified ER physicians. And if that is a specific cost to you because you have to have those types of physicians, that just consider that as you're reporting this out. 78 through 83 are all other specialists. Now, interestingly enough, if you dig into the Orange Book and start looking at this, the actual criteria state that internal medicine you have to have, but cardiology, GI, infectious disease, pulmonary medicine, and nephrology, it states that you have to have consultation available within 30 minutes for a 3. With that being said, if some of you have to pay to have that consultation available within 30 minutes, then that needs to be reported here. If as a 3, you have that resource and you are paying them, you only report your portion attributable to your trauma patients. Line 84 does not really apply to us because it's surgical residents. So again, that was mainly for level 1s, and we are not level 1s. So we'll ignore that one and move on to line 85. Line 85 is the payment for uninsured trauma patient care for all specialties. So if your facility has a way to compensate physicians who provide care to uncompensated patients, then that needs to be reported out here for the calendar year 2019. If there was something that you did, some program where trauma patients with no funding source had where physicians could apply for reimbursement, that's where this would get reported out. This was left in here from our level 1 and 2 survey where there was some reimbursement at the time. So we just decided to leave it in here for the 3s and 4s too, in case there are opportunities or ways that physicians do get payment. 86 through 88 are in-house OR availability. Now, as a level 3 or 4, you're not required to have in-house OR availability 24/7. However, if your facility is large enough that you do, and there is some of that rationale is based on your trauma, for your trauma patients, then you would report that cost out here. 89 is your dedicated OR cost, 90 is your cost of in-house OR availability. The last parts of the survey are education and outreach. So again, you're going to talk about 92, 93, and 94 are any programs that you sponsored or held during the calendar year 2019 that were injury prevention related, done with the community, or again for EMS, for any of your healthcare professionals providing education. Now, salary time does not get included in this. This is travel, the cost for courses, the cost for training, any supplies, any material. If there were personnel costs, that's included in the administrative section above, so you're not going to include that here. The 95 is an outlying hospital education that's a requirement for 1s to do it's an outreach for smaller facilities in their area and whatever cost they may have had. But if there's something that you did for as a facility for trauma, you can include that here. The last part is either physician CME or healthcare CME, healthcare provider CME. So the physician CME, interestingly enough, over time, the American College of Surgeons has dropped a lot of their CME requirements. And so now the current requirement is 36 hours every 3 years for your trauma medical director and your trauma program manager. So those are the only CME costs that we're looking for, or continuing education costs we're looking for in the trauma department. The registrar, actually, I misspoke. The registrar is also required to have continuing education. So that is where those costs are reported here. There are some providers in the book, and it's referenced in that 2-16 that are required to stay current in ATLS. And if you fall into that for your level 4s, then you would report any cost from 2019 to maintain that current status in that column. 102 through 105 are the ones that I told you in years past had to have CME credit, but now they do not. So we're no longer capturing that. But just to keep the tool looking the same, we just grayed out that area so you don't have to report those things. The last part is the trauma-related hospital staff education. So again, as a trauma center, we are required to keep our nurses and our staff current on trauma assessment, trauma care for our trauma patients. So in whatever courses or whatever activities you do for your staff in the emergency department, in the intensive care unit, or surgery PACU, you need to report that for 2019 here. Interestingly enough, as we were digging through the book and going back and adding these references to all of these line items, we found a requirement for level 4s to have pre-hospital and hospital-based provider training. So 4s, this one is unique only to you, that there is that you have a responsibility for that. And if you did any of that in 2019, report that out here, please. That being said, and I did not say this before, but if there are things that you didn't do, but you can see now, oh, we were supposed to be doing this, or we were supposed to be doing that. If you didn't do it for 2019, just put you didn't do it. It's okay. I think moving forward, what we're trying to determine, maybe you did not have the money, you did not have the resource, whatever it may be. I think we're just trying to grasp actual cost here. And there are other centers that may have done it that we can pull from and gain ideas, or the commission can. Regina can, as she's moving forward with budgeting for level 3s and 4s. The last part of the survey, and Liz, I think it's 112 through 130, just ask you questions. What was your original trauma center designation? What year was it? What level were you? Have you had an ACS visit? Have you had an ACS consultative visit? How much did it cost if you did? Do you have plans to pursue ACS verification in the next 3 years? And what is your current state designation? And when was your last state designation visit? So that's it in a nutshell. Jessica, do you have anything else to add?
I will just add that when you're submitting this survey back to us, please make sure that it is in Excel. And it hasn't been a PDF or a printout, because we will need to be able to use the data, transferring it from Excel. I think that's it, Kelly.
Okay. All right, Liz, you want to take it?
Yes, ma'am. Thank you. That was a great job in just a little less than your allocated 30-minute time. So good job. Sorry, I was just following up on a question in the chat box. I know that was a lot of information. I do want to open it up to questions, just reminding everybody those key dates again are on that form that or the PDF that we sent out, that we want the completed tool by October 29th. So you have about a month to get this completed, and that we're going to do another follow-up virtual session if you're interested. It's not required that you attend it, but some of you, since this is the first time for 3s and 4s doing this, I do anticipate that you will have questions. It's probably not until you actually get into looking at these costs will these questions come up, and that we would like to have them submitted. You can submit them to me, and the next page of that PDF has in the FAQs my contact information, which you all have from the invite. I will say that there's been a lot of questions in the chat box about, well, we were designated at a different level in 2019 than we are now. That is okay. Just send in your costs and put, you can see that what Kelly just went over on lines 112 to 130 asks for what you were designated at. Just send them in for us and we will figure out how to attribute those costs, because even if you weren't designated, one of the things that this will help with is a little bit beyond the scope of this project, but we'd like to develop a formal startup grant process, because you probably didn't get a whole lot of money to get your program going. And we realize if we want to try to recruit targeted centers into the system where we need additional trauma center support, it would be nice to have some sort of startup grant process. We've done some of that with level 2s in the past, but we need to figure out what that looks like for 3s and 4s. So I think even if you weren't designated or you were at a different level, send it in, let us know. One of the real helpful things, I just wanted to point this out before I want your feedback and questions and answers, is that for level 3s anyway, you will, some of you may not be aware of this, and it's in your contract that you will have to be ACS verified to be eligible for Trauma Commission funding by June 30th of 2024. And we're putting together a way to reimburse you for your ACS consult visit. That's usually the first part of that. We could have a whole webinar just on that. In fact, we probably will have to have a webinar on that. But I think where this will really help is before the bulk of folks are ACS verified, you may see that there's an increase in costs between what it costs you to maintain readiness as a state designated center versus what you have to have in place in order to be an ACS verified center. And I think just the exercise of going through the different criteria and looking at where Kelly has put the actual criteria in the orange book, for those of us who have been looking at the orange book or whatever color, cover color iteration it has been through the years, you can look at this book 100 times and you'll find something different. So it can be a little bit confusing. It can be a little bit overwhelming. So I'll just open the floor. I'm monitoring the chat box. That's really been the bulk of the questions so far. If you don't want to talk, yes, we can make the recording, Amy, available. We can potentially, we'll put it up on our YouTube site. I'll send a link to that in the email. So thanks for asking that. Anything else? If you don't want to speak up, again, feel free to put it in the chat box. And I know it's a lot of information, and it will really help us kind of figure out what, again, the stipend level. I think Katie's on the call. If you're a level 4, I think your total, your registry plus your readiness cost contract right now with the commission is only somewhere around $13,000. For level 3s, it's about $55,000 or $57,000. As Dr. Madero said, our hunch is that's not enough. And so we need to really figure out what this looks like. For those of you, even if you don't have all those subspecialty liaisons, it costs a lot of money to maintain physician contracts. We understand that. So we want to know what those costs are. And so we can try to find a way to reimburse you at a better level. I'll just give it a couple more minutes for, is this based on NTDB patients? So good question. So Kelly, I'm going to scroll back up to that part on the survey. At the top. So we're actually asking Kelly, if you want to clarify this point again. You did it so eloquently. Oh, you're muted. Sorry.
Okay, so this is we're keeping this, again, this survey the same as what we've done for 1s and 2s in the past. And this is what we've always looked at, are the NTDB criteria patients only. So your activations that go home from the ED don't count. Of course, your transfers out will, because that's one of the criteria. And then the blue again are your admitted patients. So yes, the answer is yes.
That's a great question. So you may have 100 patients, in your registry. If you're level 4, you might not have any admissions. We understand that. So so don't panic if you don't have any of the admitted patients. You still have NTDB patients because you probably have a lot of patients that transfer out or perhaps die in your ED or whatever other NTDB entry criteria they meet for your trauma registry. So this is where trauma registry really needs to talk with finance so you can kind of understand. You have to know what your number is. And we're willing to help. Myself, Kelly, Gina, who works over our GQuIP collaborative now. We all have lots of experience in this, and we can help you run reports. And honestly, this is really a helpful exercise in just understanding what the financial burden is for trauma in your center, really. And we need to understand that again, so we can fund you at the correct level. None of what we receive here, just in case, just to reiterate, I think Dr. Madero said it, but if you're, as I mentioned, that we, if you're level 4 and you get funded at $12, $13, $14, $15,000 a year, and for some reason this comes back and says your readiness costs are $10,000, we're not reducing your readiness reimbursement. We're not reducing anybody's costs based on this. This is one tool to help us figure out what this looks like for you. I think after we get done with this, what we'd like to look at is uncompensated care, because 1s and 2s get an uncompensated care allotment. And we know that patients who don't have any source of insurance also impact your bottom line. So we need to understand what that looks like as well. But we're starting with the readiness costs first. And then, yes, Jessica, you heard that right. We're going to go into the uncompensated care for 3s and 4s. So,
Liz, and I think that's where I was going to when I said if some of these column L's total actual costs are 0, but it says in there that you're supposed to do injury prevention as a 3, but for 2019 you didn't. Report what you did. I mean, report the 0, but we all understand that especially with 3s and 4s, smaller centers, everyone wears multiple hats and things may not be done as they were supposed to. And I think this will help to determine, it helps to, between finance and trauma, to talk through, this is what's required of us and we're not able to do it because of X, Y, or Z, and maybe push for additional funding from a state level to the center so that the center can support trauma in getting what they need to provide to meet the compliance.
great, Kelly. Thank you. And I think, Jessica, are you okay? Some of the FAQs, we asked people to, make notes or whatever. So they're going to turn this back to you as an Excel spreadsheet. So can they make notes and make column M bigger and just make notations as they have questions? I think that will help as you engage them with the questions. Okay.
Exactly, Liz. That would be very helpful. As Kelly was saying, if you don't have that, that would be an appropriate place to say, we had 0 costs, but we didn't have that this year. So yes, that'd be very helpful.
All right, so crickets is just that either everyone is really overwhelmed or they're just digesting it. So we will give you back a few minutes of your time and go ahead and wrap up. But we remain open and willing to answer any and all of your questions. So please, you don't have to wait until the deadline of October 15th to send questions in. We will, I will keep them as we move forward. And as I mentioned in my previous email, we'll add to that FAQ document. Jessica has done this. She's been with us from the start, really, for all of the readiness costs as well as the uncompensated care. So you have folks, and I've participated in one survey. Kelly's done a survey, and Regina's been here since the beginning of time. So she's been involved in all of them, and as well Gina. So We've got a lot of folks that have had a lot of experience with this. This is by no means a perfect science, but it's the best that we can have and a way to really kind of quantify the burden that you have so we can figure out where you need to be. So with that, thanks to Kelly for doing all the work to try to get this to a place where you could understand it, and to Jessica and to Dr. Medeiros. And we look forward to seeing your submissions. So thank you all for participating.